Non-Neoplastic Cellular variations in cervical cytology. Under the Bethesda System, squamous metaplasia, keratotic changes, tubal metaplasia, atrophy, and pregnancy-associated changes are non-neoplastic cellular variations with a negative for intraepithelial lesion or malignancy, or NILM. Their specific mention in the report is optional. Their importance is diagnostic because several closely mimic epithelial abnormalities. The aim is therefore to recognize their cytomorphology and identify the features that keep them benign. Squamous metaplasia. Squamous metaplasia is the physiological replacement of endocervical columnar epithelium by squamous epithelium within the transformation zone. Cytologically, metaplastic cells range from immature to mature forms. Immature squamous metaplastic cells occur singly or in cohesive sheets. They are round, oval, or polygonal, with dense cyanophilic cytoplasm and relatively high nuclear to cytoplasmic ratios. The nuclei are round to oval and relatively uniform, with smooth nuclear contours and finely granular, evenly distributed chromatin. Cytoplasmic processes may produce a characteristic spidery appearance, particularly in conventional smears. With maturation, cytoplasm becomes more abundant, and the nuclear to cytoplasmic ratio decreases, while the nuclei remain bland. The major differential is immature squamous metaplasia versus ASC-H or HSIL. Both may contain small cells with high nuclear to cytoplasmic ratios, so N:/C ratio alone is insufficient. Benign metaplasia maintains nuclear uniformity, smooth nuclear membranes, fine chromatin, and orderly architecture. HSIL shows disproportionately increased NC ratio, greater nuclear variability, irregular nuclear contours, and abnormal chromatin. Therefore, immaturity is not equivalent to atypia. A high N:/C ratio becomes concerning when accompanied by genuine nuclear abnormalities. Keratotic changes. Keratotic changes include hyperkeratosis and parakeratosis. In hyperkeratosis, the smear contains mature polygonal anucleate squamous cells, sometimes with ghost-like nuclear outlines. In parakeratosis, keratinized cells retain their nuclei. They are usually small, round to polygonal cells with dense orange ophilic cytoplasm and small, bland, pycnotic nuclei. They may occur singly, in sheets, or form keratinized whorls or squamous pearls. The major differential is benign parakeratosis versus HPV-associated squamous abnormality. Keratinization or orangeophilia alone does not indicate dysplasia. Benign parakeratotic cells retain small, regular nuclei. Nuclear enlargement, hyperchromasia, irregular nuclear contours, increased N:/C ratio, or significant pleomorphism should raise concern for an epithelial abnormality. The dossier specifically identifies small, bland, or pycnotic nuclei versus enlarged, irregular, hyperchromatic nuclei as the key first discriminator. Parakeratosis should also not be confused with dyskeratosis. Parakeratosis may be benign, whereas dyskeratosis refers to premature keratinization of individual cells and becomes concerning when accompanied by true nuclear atypia. So, the cytoplasm identifies keratinization. The nucleus determines its significance. Tubal metaplasia. Tubal metaplasia is a benign replacement of endocervical epithelium by cells resembling fallopian tube epithelium, including ciliated, secretory, and intercalated or PEG-type cells. Cytologically, the cells occur in cohesive sheets, strips, or pseudostratified groups. Nuclei may be elongated and crowded but remain relatively uniform, with fine chromatin and preserved polarity. The most characteristic features are apical cilia and terminal bars. The major differential is tubal metaplasia versus endocervical adenocarcinoma in situ, or AIS. Tubal metaplasia favors cilia, terminal bars, fine chromatin, relative nuclear uniformity, and retained polarity. AIS shows more convincing nuclear atypia with hyperchromasia, increased NC ratio, crowding and stratification, and loss of polarity. Apoptosis, mitotic activity, feathering, and rosette formation further support AIS. The dossier identifies cilia and terminal bars together with fine chromatin and retained polarity as the strongest initial combination favoring tubal metaplasia. However, cilia should never be used as an isolated rule-out for neoplasia. Nuclear morphology and architecture of the entire population must still be evaluated. Atrophy. Atrophy results from reduced hormonal stimulation and is most commonly encountered after menopause. The squamous epithelium becomes thin, and cervical cytology is dominated by parabasal cells. These are small, round to oval cells occurring singly, in sheets, or in syncytial groups. They have relatively high NC ratio, but their nuclei are typically uniform with smooth contours and fine chromatin. Despite their immature appearance, cellular polarity and population uniformity are preserved. Atrophic smears may additionally show inflammation, granular basophilic debris, degenerative cells, nuclear pycnosis, and pseudoparakeratosis. This combination can make the smear appear considerably more atypical. The critical differential is atrophy versus ASC-H or HSIL. Atrophic parabasal cells naturally have high NC ratio, while degeneration may cause hyperchromasia and chromatin clumping. Therefore, small hyperchromatic cells with high NC ratio are not sufficient for HSIL. Benign atrophy favors a monotonous parabasal population, smooth nuclear membranes, relatively fine chromatin, preserved polarity, and orderly arrangement. HSIL favors significant anisonucleosis, irregular nuclear membranes, genuinely abnormal chromatin, disproportionate N:/C elevation, and a dysplastic or disorganized cellular population. If genuine atypia is present but insufficient for definitive HSIL, ASC-H may be appropriate. Atrophy itself, however, should not automatically trigger ASC-H. The practical distinction is that atrophy is immature but orderly. HSIL is genuinely dysplastic. Pregnancy-associated cellular changes. Pregnancy commonly produces glycogen-rich intermediate cells, including navicular cells. Navicular cells are modified intermediate squamous cells with abundant glycogenated cytoplasm, often with a boat-shaped configuration. Their nuclei remain bland, and the cytoplasmic clearing is poorly defined. This distinguishes them from classic koilocytes, in which the perinuclear halo is sharply defined and accompanied by HPV-associated nuclear atypia. Decidual cells may occur singly or in groups and can show relatively large nuclei, high NC ratio, and hyperchromasia, potentially mimicking HSIL. Features favoring decidual cells include smooth nuclear contours, smudgy rather than coarse chromatin, and often conspicuous nucleoli, interpreted in the appropriate pregnancy setting. Pregnancy may also produce area stellar-type glandular changes, including cyto and karyomegaly, vacuolated cytoplasm, and enlarged nuclei with smudgy or ground glass chromatin. These changes may mimic glandular atypia or adenocarcinoma. Rare trophoblastic cells may also be encountered, particularly in pregnancy or postpartum specimens, but they are a secondary diagnostic pitfall rather than a major component of this category. The research dossier specifically recommends keeping trophoblastic cells to a brief warning rather than a separate section. Thus, pregnancy-associated changes are interpreted using nuclear quality, cytoplasmic differentiation, architecture, and clinical context rather than pregnancy status alone, integrating the differential diagnosis. Across all 5 variations, no single cytological feature should determine the diagnosis. A high N:/C ratio occurs normally in immature metaplasia and atrophy. Hyperchromasia may result from degeneration. Pseudostratification occurs in tubal metaplasia. Keratinization can be benign. Even cilia or pregnancy-associated morphology should not independently exclude neoplasia. Instead, evaluate nuclear contours, chromatin, population uniformity, N:/C ratio in relation to cell type, cytoplasmic maturation, polarity, cohesion, architecture, and background. This pattern-based approach is the central diagnostic principle emphasized by the research dossier. Benign variations generally retain relative nuclear uniformity, smooth nuclear membranes, bland or fine chromatin, appropriate cytoplasmic differentiation, and preserved organization. True epithelial abnormalities are favored by significant anisonucleosis, irregular nuclear contours, abnormal chromatin, disproportionate N:/C elevation, and loss of normal polarity or architecture. Depending on the lesion, mitosis, apoptosis, feathering, or tumor diathesis may provide additional evidence. Bethesda reporting. All 5 variations remain within NILM when there is no cytological evidence of epithelial neoplasia, and their individual mention is optional. Recognition and reporting are therefore separate decisions. However, a benign background must never be used to explain away genuinely abnormal cells. If criteria for ASC, US, ASC-H, LSIL, HSIL, AGC, AIS, or malignancy are fulfilled, the appropriate epithelial abnormality must be reported. The practical approach is therefore identify the benign variation, assess its nuclear and architectural features, exclude its important mimic, and retain NILM only when the complete cytomorphological pattern supports a non-neoplastic process. In the next lecture, we will continue the NILM category with organisms encountered in cervical cytology and their reporting under the Bethesda system.